So I'll be speaking very briefly on robotic total knee replacement. That's the flavor of the day. And right, knee replacement keeps on changing. We try and develop newer and newer knee replacement. And the reason for that is 10 to 15% of the patients with knee replacement are never happy. And sort of people try to strive to bring down this number. And in the past, we've had patient-specific instrumentation designed for individual customized patients. We had patient-specific implants after the instruments implants so that fits the patient perfectly. And this idea was there to bring down the number of unhappy patients. Then we had sensors in the knee replacement. I mean, we have spacers to find out the flexion and extension gap and balance the knee. And these sensors tell us whether the medial side is tight, loose, and the ligament is tightness or looseness is told by the sensors. And then we had navigation. Now, navigation, when it came many years ago, about 90% of the surgeons in the US, they use navigation. Hello? What you said something, Dr. Chang?
No. Continue, please.
Oh, actually, people are joining in, so that's why.
Oh, okay, I'm sorry. Yeah. So this navigation, about 90% of the doctors in the US played around with it. But now if you see only 5% do navigation. So all these patient-specific instrumentation, specific implants, sensors with ear and navigation, they've all gone out of the window. And now the robot has come. So when the robot initially came, I was very skeptical. I mean, you'd like robotics to be done in, let's say, general surgery or more so in urological surgery or in gynecological surgeries, where your hands don't reach the deep things in the pelvis and you have to make a big cut. But that robot was very helpful. And I used to think, anyway, the knee, you've opened everything, you've done a minimally invasive knee replacement. Why need the robot? But now, after using the robot, I believe that it is fantastic, very precise. It sort of the amount of tissue damage that we do during surgery is very little. Patients have less pain and they regain their movements very fast and their activity very fast. So I think robot is here to stay. That is something which has transformed my life and I believe in it. The other things that I do, which most surgeons don't do, only about 10% of surgeons would do a subvastus approach. In subvastus approach, what I do is this is the quadriceps. So from the femur, I lift up the whole thick quadriceps muscle, right? Don't cut it like a regular knee replacement. And once we have lifted up the whole thing, we have done the whole surgery, I just put back the muscle, just plops back into place. And you not just need to put a few sutures and the operation is done. And the beauty is the muscle is not damaged, so muscle remains strong. And so you get good range of movements very quickly, and the patient can walk without support very quickly. So this is the subvastus that I believe in. But now I do a few which goes through the muscle, not like the regular knee replacement approach, but a smaller mid-vastus. And this is because the robotic arrays I feel is easier to place when I do a mid-vastus. And the beauty of these approaches is because you've not damaged the muscle much, the patellar tracking, which might be a problem after surgery, the patellar tracking is very pristine, very accurate. The other thing that I do, which again about 20% of the surgeons all over the world do, is I retain the cruciate ligament. Now, those two ligaments are there, anterior cruciate and posterior cruciate. Anterior cruciate gets damaged during the arthritic process, and the posterior cruciate I always preserve. The reason for that is these ligaments have got proprioceptors, nerve endings. So it's not just a plastic and knee, a metallic knee. The brain gets some feedback from these ligamentous proprioceptors. So you have some joint sense and position, and that gives a better walking gait and better stair climbing experience. So these are the two things I do. And if you retain the cruciate, you don't remove too much of bone. So in case, God forbid, you have to go in for a revision, your bone stock is maintained. Now, this is what Dr. Hegde has said. So he's already told you about this, that we probably replaced both hips and both knees in a patient. She was 59 and about 15 years ago. And she came to us like a frog lying in the bed, all the joints stiff. And she had flexion deformities of the hips of about 50 degrees and the knees also around 45, 50 degrees. So I'll show her. These are her x-rays. The knee, I mean, you don't see any joint spaces are totally gone. Now the problem in front of us was, how do we proceed? If we do one joint after the other and other, I mean, rehabilitation becomes so slow and so poor. And normally, when you're doing in orthopedics, the golden rule, the rule of the thumb is do the hips first, followed by the knees. Now, here, if we had done bilateral hip replacement in the first sitting, with the knees in 45 degrees flexion, how do you nurse the patient? The knees would be sort of standing up with that amount of flexion. So after deciding quite a lot, we said, okay, we worked up the patient. Apart from rheumatoid, she doesn't have no other comorbidities. So we'll try and do all the joints one by one. So what we did initially, we put the patient prone and we release the hamstrings, the medial and lateral hamstrings behind the knee, because they cause a lot of flexion deformity. And with that, we brought down the flexion deformity. And then we turned the patient to one side and did one hip. And then we turned the patient to the other side and did the other hip. And finally put the patient on the back supine and did both the knee joints. Now it took us about 7 hours. Total blood loss was only 800 ml. Not because I'm a very great surgeon, but then there is something called a tranexamic acid. This has been there for about 50 years, but we orthopedic surgeons discovered it a little late. And it's a marvelous drug which brings down the blood loss. This lady's hemoglobin dropped from 12 to 9, and we only transfused 2 units of blood. When I was in England, the rule of the thumb was that if you do more than one major joint, the patient has to go into a ICU, which is a good rule. And but this lady was so stable, was doing so all right, that we shifted her to the ward. One thing is the cost factor. In India, we need to consider the cost factor. If you put them in ICU, the bill shoots up. And that's the hip replacements, both hip replacements done, both knees done. And that's the lady. The knee is out straight, and there the knees are bent. And second post-op day, she started walking with support. Like Dr. Sanjay was telling, we have done the first your daycare knee replacement in India. The reason for that again was, India is a vast country, lots of population. The number of hospitals are few, number of hospital beds are few. And with this avalanche of patients, tackling them becomes very difficult. But if you do a quick turnover, then you treat more patients, the bill comes down, and that's how we did the first daycare knee replacement. Patient came in at 7 in the morning, and by evening the patient was home. Actually, it took quite a lot of time discharging the patient because we did not have a code for a daycare knee replacement, and the billing people were seeing stars, what is happening. But then finally the patient went off home, and I think nowadays we don't do daycare, especially if Dr. Chang, if you're sending patients from Thailand and out of the country, what we'll need to do is to keep them for about 2 days. And as Jatinder was saying, keep them in a service department or a hotel room and let the physios go there and work on them. So the nosocomial infection, hospital-borne infection and things would be much less. The bill also would be controlled. And with the physios working on them, they would rehabilitate faster and will send them back to the country only after a couple of weeks when the wounds have healed and when the patient is doing well. I don't believe in doing a quick surgery and putting them on the flight and sending them back. And if they have problems in their home country, it's very difficult to talk on the phone and sort it out. So keep them here for 2 weeks, make them perfectly all right. After all, they're our guests and they've come with very high hopes from a different country. And we've got to do our best for them, and we'll always do our best for them. And this is a short presentation, Dr. Chang. I don't know. I mean, there'll be lots of questions and answers, and there may be other speakers too. I'm actually on holiday in Rajasthan. That's in Jaipur. That's the capital of Rajasthan. So holiday was a bit out of yeah, because the US Vice President, he dropped in with his family to Jaipur. He's spending his holidays here. And because of him, the whole city is in a lockdown. So I can't move around and see the things that I've come to see. But it that part has been a nice holiday. And Dr. Chang, it will be a pleasure to host you in Bangalore and hope to meet you soon. Thank you.
Thank you very much, Doctor, for your nice presentation.
Thank you, Dr. Chang.
And can you tell us one indication for the knee replacement? What stage of the knee arthritis should be done the replacement?
That's right. The most important indication is pain and loss of mobility, right? If the patient says that, doctor, I used to walk 10 kilometers a day, I used to love walking, and now I can walk only for 500 meters, right? And doctor, nowadays I have to take a painkiller morning and evening. And many of them land up with kidney problems because, in India, sometimes you go to a shop and you say, I've got pain. And the shopkeeper will give you 5 different types of painkiller without a prescription, which is unlawful, but it sometimes happens. And, you know, these people, like they eat food, they start taking painkillers. So if you come to a stage like that your mobility is so restricted and you have to rely on painkillers, it is best to have a knee replacement done. X-ray wise, you have to see that how bad is the arthritis, and you should always wait when the bones rub against each other. We call it bone on bone. When it's a very early arthritis where you hardly see any joint changes, it's very unfair to do a knee replacement in those cases. And they are the people who remain unhappy. And I think these are the most important indications for a knee replacement for me.
So in case the patient for the partial replacement and total replacement, which one is the better? Or one we should do partial replacement and one we should do total replacement?
Oh, yes. The thing now with the robotic, partial knee replacements have come in. Okay. But if you look at literature, partial knee replacements came and went and came and went. The reason for that was the rate of revision after a unicondylar knee revision in some series was as high as 28%, right? So therefore, I prefer to do a total knee replacement because the cost of a unicondylar knee replacement is also massive, is as much as a total knee replacement. And because the volumes are less, in some places the costs are more because the implants are costlier because the number of implants used is much less. And if you have to do a revision in these cases for whatever reason, the revision is like a total knee replacement. It's not that you've done only the medial side or the lateral side, and you just sort of revision would be very simple. No, the loosening eats away a lot of bone, and you have to do a proper revision.
So another question after the knee replacement, should we give injection, lubricant injection, or we don't need to give it?
Yeah, I mean, many patients come to me and say, Doctor, knee replacement. No, we don't want to go in for a knee replacement. That's a massive surgery. Why don't you do something? And for most of our people, when they come to me first, I never offer knee replacement as the first solution. What I tell them is do a course of physiotherapy, okay? And change your lifestyle. Don't sit on the floor. Don't use an Indian style toilet. Don't run up and down stairs. Okay. And if you do that, your graph of degeneration decreases. Okay. And try and pull as much time as you can, especially the younger the patient, the more we ask them to wait. The other thing that we need to sort of know is young patients, we need to sort of withhold the knee replacement for some time. But having said that, if you've got a rheumatoid disease or something where the disease has destroyed the joint completely, we need to do the knee replacement early.
How about the PRP injection or stem cell
Oh,
injection? It can help also before knee.
exactly. I sorry, that was your question and I missed it. Yes, doctor. So once I've done physiotherapy and the lifestyle changes, if it does not help, we give them some glucosamine, chondroitin sulfate, or some collagen supplements. The American Academy says that if you've got bone and bone, all these things don't help. But these are nutritional supplements and they help. I mean, they can help, but at least they won't harm. It's a nutritional supplement. So we give these supplements and if things don't improve, they say, Doc, anything else? And then I say, yes, I could give you, inject your knee. And there is steroid, which is the cheapest one. And I could give you an injection of steroid, but I don't like giving steroids inside the knee. If I've done a steroid injection in the knee, I will not do a knee replacement for the next 6 months. The chances of infection goes high. The other thing is concentrate the blood and inject some platelets. Like 10 years ago, people used to do stem cells. Yeah. But stem cells is probably a little experimental still and nobody. But yes, PR injections can be given. But I have to tell them that, look, you are spending money. I'm putting something inside your knee, and this is not going to make your knee like a 16-year-old. Your arthritis has settled, and there is nothing except God who can rebuild your knee and get all your collagen and cartilage perfect again. But yes, you do get some temporary relief, and I'll not be able to tell you how long. They all ask, Doctor, how long? How many months? How many years? And I say, I can't. I mean, sometimes I ask them that, can you tell me how long will I live? Which is a bit of a joke, and some patients laugh that, yeah, but these are temporary measures. And when the patient needs a knee replacement, then I do a knee replacement. Otherwise, I tell them to wait.
Based on your experience, so when after the patient uh, done knee replacement, and is there any pain reoccur? like for example, you do knee replacement today or next 5 or 6 years later, does the patient complain of knee pain again or no case?
Yes, Dr. Chang, you're very right. When I do a knee replacement, I mean, the first 2 days are under the anesthetist. The patient is the anesthetist baby, and they take care of the pain. But once all these epidural and spinal, all my kids are done under epidural and spinal, unless they've got some major back problem or a cardiac problem. I mean, most of them are done under local anesthesia. Now, once these pumps and think tubes are removed, they have pain. And many of the patients says, Doctor, I've had one knee done. I'll never, ever, ever, ever have the other knee done. Okay, and initially they have that, but gradually things improve. And 6 months later, all these patients come wagging their tail, doctor, do the other knee. So yes, knee replacement is a little painful. They have to undergo physiotherapy, and while doing physiotherapy, they have pain. You know, the physiotherapist is bending the knee in one direction, and they're having pain, and they're pushing the physiotherapist away. So this is the time where you need good physiotherapists, and we have got good physiotherapists here who coax the patient and sort of encourage them that no, don't fight, relax your muscles, relax, take some deep breaths and bend your knee and get your movements back. And I think when the patient comes to us in the OPD, we tell them that also, that look, this is what you've got to do, this is what you have to expect, and if you do this, you'll recover much, much faster.
So for the patient who have the knee arthritis, I mean the knee pain for both sides, would you recommend to do knee replacement at the same time or do one by one?
Yes, Dr. Chang, I would say do both together. But before you do both together, you have to get a medical, cardiac, and anesthesia evaluation done. And if they have got other problems, neurological, so all the tests you have to do, you have to do your workup. After all, you're sort of operating on a human being, not a chair or a table. Now, if the patient has any cardiac anomaly, I'll never ever do both knees together. Right? There are certain guidelines which have been given by the American Academy, and I follow the same guidelines. So, if there is no major cardiac anomaly, and I mean, diabetes, blood pressure, they are not problems. They can be tackled. We can sort it out. We can control it. And I would rather do both knees together. Rehabilitation is much faster and better because most of our patients have badly deformed knees. They wait and wait and wait, and then they come. And so doing two together is what I prefer. And in case I cannot do two together, in the olden days we should do the other knee after a day, after 2 days, after 3 days. But again, the American Academy has said you cannot hit the patient so quickly in such a short period. You have to give a gap of about 2 to 3 months. So, weighing everything, I usually prefer doing both knees together. And literature also supports this.
I think Dr. The is writing something on. Okay, thank you so much for your interesting topic. They have written over there. Any other questions you can shoot in the chat box, or you can, tell Dr. Chang as well. And this will be a recording, and it will be on the Telegram group itself. And Dr. Chang, I think it's 5:30 p.m., 5:45 p.m. over there, and people are traveling to their homes, right?
6 p.m. now.
Yeah, okay.
Okay, yeah, I think it's all. I think.
So, okay. So, should we close this thing? Close the webinar? You tell me.
Yeah,
Or
I can close because no more question.
Okay, so like coming in the coming days, this is just the starting. So we in the coming days, so we can arrange more sessions like with the maximum number of participation, and you have to choose the day where when the people are not, occupied.
Yeah.
Days when I'm not on holiday, I'm,
Yes.
I'm now going to, once this finishes, I'm going to go back to my gin and tonic and see a bit of Jaipur once Mr. Vance has settled down and the city is open again.
Ah, Mr. Vance there. Okay.
Okay. Thank you so much. Thank you so much, senior consultants and everyone. So we hopefully we'll in the coming time, so we can arrange more sessions, one-to-one interactions, and also we can discuss cases. And Dr. Chang, for anything you needed for about the if you need any contact for senior consultants, you can ping me. I will tell you. I will share the number with you. And also there are some orthopedic cases is there. And also, sir, can you please tell about the Mako machine a little bit, like in your own words? Dr. Sanjay or just Dr. Chakravarti regarding this new machine?
Or the new one. This machine has been there for donkey's years. It's not new.
Uh,
When I used to go for the American Academy some 15 years ago, the Mako machine was there, but it's been on trial for the longest period, and it is no doubt the best in the market. There's no confusion about that. And initially they were trying it with unicondylar knees, but now for hips, for knees, for everything, the Mako machine is there, and I've used it. And like I said, I was pretty skeptical initially, but now I feel it's so nice, so easy, so accurate, and patients recover so much faster. It's a beautiful machine, excellent machine, except for the cost, of course.